Hello, my name is Filipa Farinha. I'm a Portuguese rheumatologist and I'm currently a PhD student at University College London in the United Kingdom. I was asked by the European Lupus Society to record a podcast on the management of lupus nephritis. Kidney involvement is a frequent and severe manifestation of SLE associated with increased morbidity and mortality. In this podcast, I will talk about the management of lupus nephritis in adult patients with SLE, covering aspects such as when to do a renal biopsy, what are the goals of the treatment, who should receive immunosuppression, and which medications to use for initial and subsequent treatment. I will mainly take into account the most recent recommendations from the EULAR in collaboration with the European Renal Association and the European Dialysis and Transplant Association, which were published in 2020. All SLE patients with any sign of kidney involvement should be considered for a renal biopsy. And what are the signs of kidney involvement? These can be hematuria, proteinuria above 500 milligrams in 24 hours, or UPCR, which is the spot urine protein creatinine ratio, above 500 milligrams per gram, or 50 milligrams per millimole, and an unexplained increase in the serum creatinine, even if it's still within the normal range. We know that mild clinical presentations can be associated with active and sometimes aggressive histological lesions, and there is evidence that earlier use of biopsy is associated with better outcomes. Although the current classification of lupus nephritis, the 2003 ISN-RPS system, is based exclusively on glomerular pathology, there is recommendation for additional assessment of activity and chronicity indices, tubular interstitial lesions, and thrombotic and vascular lesions that may be associated with antiphospholipid antibodies. Management of active lupus nephritis includes an initial period of intense immunosuppressive therapy, the induction treatment, followed by a longer period of usually less intensive therapy, the maintenance treatment, to consolidate response and prevent relapses. Goals of treatment include patient survival, long-term preservation of kidney function, prevention of flares, prevention of organ damage, management of comorbidities, and improvement in quality of life. We should aim for a reduction in proteinuria of at least 25% at 3 months, 50% at 6 months, and a target UPCR below 500 to 700 milligrams per gram by 12 months. However, it is important to note that many patients, especially patients with nephrotic range proteinuria at baseline, may need additional time, up to 6 to 12 months more, to reach complete clinical response. Furthermore, if the patients already have some chronic lesions with glomerular sclerosis, they may have persistent proteinuria. And do all patients need immunosuppression? Patients with proliferative lupus nephritis, which is class 3 and 4, membranous lupus nephritis, or class 5, and mixed proliferative and membranous lupus nephritis should receive immunosuppressive agents in combination with glucocorticoids. Mesangial lupus nephritis, which corresponds to class 1 and 2, does not usually need specific immunosuppressive treatment. Now I'll talk about induction treatment. For patients with proliferative or mixed lupus nephritis, the first-line options are mycophenolate mofetil, MMF, between 2 to 3 grams per day, or the enteric-coated mycophenolic acid at equivalent dose, which may be better tolerated with regards to gastrointestinal side effects. Or low-dose intravenous cyclophosphamide, the Eurolupus regimen of 500 milligrams every 2 weeks for a total of 6 doses, and both in combination with glucocorticoids. Combination of MMF, 1 to 2 grams per day, or mycophenolic acid at equivalent dose, with a calcineurin inhibitor, especially tacrolimus, is an alternative, especially in patients with nephrotic range proteinuria. High-dose intravenous cyclophosphamide can also be considered for some patients with adverse prognostic factors who are at high risk for kidney failure, such as increased creatinine, histological presence of crescents or fibrinoid necrosis, or severe interstitial inflammation. Regarding glucocorticoids, the task force recommends initial intravenous pulses of methylprednisolone with the dose depending on disease severity, followed by lower dose of oral prednisone between 0.3 to 0.5 milligrams per kilogram per day for up to 4 weeks, which should then be tapered to 7.5 milligrams per day or less by months 3 to 6. This strategy aims to reduce the cumulative glucocorticoid dose. However, current practices may vary from country to country and within different specialties. In pure class 5 nephritis, the first line is MMF, 2 to 3 grams per day, or mycophenolic acid at equivalent dose, in combination with pulse intravenous methylprednisolone, followed by lower dose oral prednisolone, which is then tapered to 5 milligrams per day or less by 3 months. Alternative options for class 5 nephritis include intravenous cyclophosphamide or calcineurin inhibitors, especially tacrolimus, usually in combination with MMF, especially in patients with nephrotic range proteinuria. One important point is that hydroxychloroquine should be given to all patients unless contraindicated, and its use is associated with lower risk of kidney flares and stage renal disease and death. And what to do if patients do not respond to this treatment? In that case, we should thoroughly evaluate the possible causes, including assessment of adherence to treatment and monitoring drug levels if possible. For active refractory disease, treatment may be switched to one of the alternative initial therapies, or we can try rituximab, 2 infusions of 1 gram 2 weeks apart. And now I will talk about maintenance treatment. Following adequate response to induction, treatment should be continued, preferably with mycophenolate or mycophenolic acid, usually at a lower dose, 1 to 2 grams per day. Azathioprine at 2 mg per kilogram per day is an alternative, especially if pregnancy is being considered. These are given in combination with low-dose prednisolone, 2.5 to 5 milligrams per day usually. And there are several adjunctive treatments that we should consider from the beginning alongside immunosuppressive treatment and hydroxychloroquine. One is angiotensin-converting enzyme inhibitors or angiotensin receptor blockers, which are recommended for all patients with UPCR above 500 milligrams per gram or arterial hypertension. It is important to keep blood pressure below 130/80. Bone protection and prevention of osteoporosis with both pharmacological and non-pharmacological measures are important. Immunizations with non-live vaccines, low-dose aspirin can be considered for patients with high-risk antiphospholipid antibody profile after balancing benefits and bleeding risk. Anticoagulant treatment should be considered in cases of nephrotic syndrome with serum albumin below 20 grams per liter. And a new point in these recommendations is that belimumab may be considered as add-on treatment to facilitate glucocorticoid sparing, control extrarenal lupus activity, and decrease the risk for extrarenal flares. And what shall we do if a patient does not respond to any of the treatment alternatives? Or if, after some initial response, a patient starts to show worsening of proteinuria and/or kidney function? Or what if there is a relapse after some time in remission? A repeat kidney biopsy should be considered in these cases. The repeat biopsy may show possible histologic class transition. For instance, a patient that was initially class 5 may transition to class 4, or possible increase in chronicity indices, showing now the presence of irreversible chronic damage. Biopsy may also show the presence of a different renal pathology requiring a completely different approach. Another important aspect in the management of lupus nephritis is concerned with family planning. Many patients with lupus nephritis are women of childbearing age and may wish to get pregnant. Pregnancy may be planned in stable patients with inactive lupus nephritis, ideally with UPCR below 500 milligrams per gram for the preceding 6 months and with a glomerular filtration rate above 50 milliliters per minute. Compatible medications such as hydroxychloroquine, prednisolone, azathioprine, or calcineurin inhibitors should be continued at safe dosages throughout pregnancy and lactation. Mycophenolate or mycophenolic acid should be withdrawn at least 3 to 6 months before conception is planned to ensure that an alternative immunosuppressive agent does not lead to a relapse. While patients are on mycophenolate and while their disease is active, they should be advised to use effective contraception. During pregnancy, low-dose aspirin is usually recommended to reduce the risk of preeclampsia. Finally, all patients with lupus nephritis are best managed by multidisciplinary teams, and decisions should be shared with the patients. Thank you very much for listening.